you're implying that you said that there are times of the month when women naturally feel lousy, a New York word, I think. I mean, yes, there are just times of the month when women feel, quote, lousy. I mean, it's just that's something to be expected, so that's normal. And so if you feel lousy at certain times of the month and you track it with your menstrual cycle and you know you're going to feel lousy, you just do, and that's how it is?
Yes. Look, if it's...
That's pretty scary, Julie, because we've got women, fortunately, I think we both agree, going into very high levels of government now, including the possibility of president. And are we to expect that on a regular... Well, no, she's too old, so she's post-menstrual. But what about...
definitely postmenopausal.
Right, but what about younger women who might be in Congress and Senate? We're going to say once a month they're going to be in a lousy mood. Watch out. I mean, I don't know if we want that.
There are some women who don't have premenstrual syndrome at all, and there are other women who are completely incapacitated by it and require hormones. The majority of other women have some change in their mood over the course of their fertility cycle, and that is normal, and there are real advantages to that, and I talk about that in Moody Bitches. But in general, women are quicker to calm themselves and get out of an emotional situation than men are, and the idea of sort of having revenge or having a vendetta or being angry and carrying a grudge for years. I mean, if you're worried about people being emotional as politicians, I think that's already been covered.
No, I'm not worried about them being emotional. My concern is more that they won't be allowed to be emotional because we live in a culture that wants to somewhat suppress emotion. We've been working on that since the 60s. Remember when George Bach wrote the book, Intimate Aggression, Intimate Enemies, where he was saying, some level of very safe, focus on very safe, fighting is healthy because otherwise you suppress all this stuff and you end up stuffed up full of junk inside, right?
Right. I mean, we all know that if you suppress a behavior, it's going to come out in perverted ways. So this idea that you can be celibate or that you can go against what your real sexual orientation is, it's going to come out in weird ways. So, what's happened for centuries is that men have had their natural emotional side suppressed, and little boys are taught not to cry, don't act like a girl. But now what's happening is that women are getting this message more and more, that it's not okay to be emotional, it's not okay to express your emotions or to feel your emotions, and these are really dangerous, unhelpful, and unhealthful messages.
Yes.
And they're getting it also from Big Pharma. I mean, I really think that the pharmaceutical industry, they're targeting women in their advertising. They're advertising in women's magazines, daytime talk shows, much more than they are in magazines or male-oriented shows in terms of psych meds. And they're exploiting women who feel vulnerable about the fact that they do get emotional. We are made to feel like this is abnormal. And I'm not talking about people with major depression who
That's right.
can't get out of bed and their sleep and their appetite and their energy levels completely distorted. And they need a psychiatrist and they need medication. I'm talking about this sort of cosmetic psychopharmacology where more and more women are on psych meds that are prescribed by non-psychiatrists. And then they have trouble getting off these meds. I mean, that's the other thing no one's talking about. It's really hard to get off antidepressants. It's hard to get off anti-anxiety medicines. It's hard to get off sleeping pills. It's hard to get off stimulants. There's millions of Americans who are taking medicine year after year after year only because they can't stop what they started. They may not need it anymore. Their lives may have changed, but they are tolerant and dependent. They cannot get off their medicines easily. And as soon as they start to pull back on the meds and feel lousy, they become convinced that they have a chemical imbalance and they need to stay on the meds, when really what they're experiencing is withdrawal.
That's exactly what Robert Whitaker said on this program, his book Anatomy of an Epidemic. Exactly what you said is what he said, namely that when people try to get off these medications, then they're running into neurochemical imbalances and they feel crazy and they think, well, I really needed the medicine to begin with, so I better get back on it.
Exactly.
Because they're going through a withdrawal, aren't they?
Right. And there's some psych meds that are harder to get off than others. I've certainly had people come to me saying, I've been trying to get off this medicine for years, but I've been on it like an extra 10, 12 years now because I haven't been able to stop. And one of the things that I like doing, that I think I'm good at, is helping people to get off their medicines. And it's a slow process, and you need to put a lot of other things in place before you start to pull off these medicines. And sometimes it's not just behavioral changes. Sometimes you need other medicines to make it easier to get off certain ones.
When I was doing drug treatment full-time back in the 80s, I was able to detoxify people from cocaine and heroin in relatively short periods of time. You know that. It's out of your system. In 3 or 4 days, you can pretty much get it out. Is that not the case? Is that not the case with some of the medicines you're talking about, or should we be creating social model detoxification centers where people can go away for 3 or 4 days and get these things out of their system?
It's not just 3 or 4 days. I mean, this is what people need to understand. Coming off psych meds takes weeks or months. It is not, in any case, a question of days. It is easier to come off of heroin or cocaine than it is to come off of most prescription psychiatric medication.
I want to repeat that for our listeners. That's very important, Julie. Dr. Julie Holland is saying that it's easier, in her experience, to come off, her long professional experience, it's easier to come off cocaine and heroin, which is a lot of my work, than it is to come off the psychiatric medicines that she is using and is encountering. That's an important thing for people to know. Is that because of the blood levels, Julie, that it gets into the blood and it takes that much longer to get out?
No, it's not. It's nothing to do with blood levels. It's a longer process, because when you take an antidepressant every day, there's all this balance that has to happen with the receptors, basically. And when you stop the medicine, your brain has to create new receptors and create a new balance. And it takes weeks and months. It's a long process. It's very uncomfortable. I often need to use other psychiatric medications to get people off what they're tolerant to or dependent to, and then I have to taper whatever I put in place to allow the first taper to happen. So it's at least a 2-step process with medication. And it's such an unnatural state. The other thing is a lot of women are taking oral contraceptives and antidepressants together. And estrogen and serotonin are really linked. They're yoked to some degree. So you have unnaturally high estrogen levels with the oral contraceptives, and then you have unnaturally high serotonin levels with the antidepressants. When you put those two together, I mean, I write in Moody Bitches about something I call the double whammy. It's a lot of women who are on oral contraceptives, the pill, and antidepressants. And it really puts you in this hyper-rational, hyper-accommodating state, where you put up with a lot of crap that you normally wouldn't. One advantage of a woman having premenstrual syndrome for a couple of days is that she becomes more critical and more irritated by things. And it's a chance to make changes in her environment and potentially in the behavior of people around her. I had a patient who called me from work because she wanted to go up on her antidepressant because she was crying at work, and you can't cry at work. But when I talked to her about why she was crying, her boss had behaved terribly and betrayed her and humiliated her in front of her staff. And if she just takes more medicine so she doesn't notice his bad behavior and she doesn't cry, that is enabling, malignant behavior to go on around her. I mean, it's not doing her any favors. It's also not doing him any favors or her coworkers any favors.
I remember when Prozac first came out, Julie, and I read an article in a paper by a very astute journalist who said that he was taking Prozac and it was putting him in a better mood and he was happier. And then he went to his mother's funeral and he realized he had no feelings whatsoever. And he said to himself, this is the price I'm paying for taking this. That's what you're talking about, isn't it?
Right. I mean, one of the prices you're paying is that it's going to be very hard to cry and to really feel emotionally connected with people.
Well, if it's hard to cry, how do you orgasm?
It's nearly impossible for most women on a solid dose of SSRIs to climax. It's a huge, huge problem. In my patient population, women complain about low libido and inability to orgasm, and it is directly affected to the antidepressants they're coming in on.
And you're saying that 25% of the women in the United States are on one of these medications? Is that correct?
First of all, in certain demographics, it's higher.
Even higher?
Over the course, if you look at all adult women in America, 1 out of 4 is taking a psychiatric medication.
Wow.
Anxiety. And now the big thing is antipsychotics. I mean, more and more doctors and not psychiatrists are prescribing antipsychotics for this kind of malaise and depression that women are experiencing.
You mean like Abilify?
I mean like Abilify. Abilify was the biggest moneymaker in America in 2013.
How do you as a psychiatrist feel about general practitioners prescribing psychiatric medicine? I know you don't want to criticize your professional colleagues, but that's an honest question.
I don't criticize my colleagues, but the truth is that because of the way medicine is set up in America right now, it's all about customers. It's all about getting people in and out of the door and seeing people for 6 or 10 minutes. A psychiatrist will spend 60 minutes, maybe even 90 minutes before they figure out what the diagnosis is and what meds they want to start. An internist, a GP, family practice person will spend 6 or 10 minutes maximum before they're writing prescriptions and the person's out the door. So, looking at a psychiatric history, a family history, looking at the genetics, looking at treatment response in families. I mean, there's a lot of things that really go into making the decision to start meds. And the biggest thing that no one is talking about is, okay, well, if we start you on meds, then what? Because you're going to feel good and it's going to feel hard to come off. So then what?
What's the exit strategy? Like when we went into Iraq, we knew how to go in, but we didn't have a way to get out, and you're saying the same thing's happening on the personal and the microcosm level, huh? If you start these medications, how are you going to get off these medications? Julie, would it be fair, excuse me, I'm going to take a quick sidebar because it's 28 minutes. You're listening to Dr. Julie Holland, who's our guest today on Mind, Body, Health, and Politics. She's talking about her book, Moody Bitches, the truth about the drugs you're taking, the sleep you're missing, the sex you're not having, and what's really making you crazy. This is an important book for many reasons, and you want to read it. Julie, I want to ask you, should we be warning people on this program who are taking these psychiatric medicines, who are not under the care of a psychiatrist, who are just taking them from a GP or an internist who sees them for 5-6 minutes? Should we be giving them some kind of warning? Should we be telling them that they really ought to get to a psychopharmacologist or a psychiatrist? What's the proper thing to do here to protect our listeners?
I think that it's always better if you can work with a specialist. It certainly is better if you're taking a psychiatric medication to be working with a psychiatrist. I think, it's a no-brainer. I think that there are parts of the country where there aren't a lot of psychiatrists and they don't have that option. But, what I talk about in Moody Bitches is that there are a lot of things that you can do to feel better that don't involve pills. And, one of the things that I focus on quite a bit is this concept of inflammation. That, you know this, I'm sure, Richard, but inflammation is the sort of breeding grounds for a lot of medical illnesses, like arthritis or heart disease or cancer or diabetes, Alzheimer's. They all have a basis in inflammation. All the autoimmune diseases have a basis in inflammation. Well, it turns out that depression and anxiety and insomnia also have a basis in inflammation. So a lot of the advice in Moody Bitches is really about an anti-inflammatory regimen, things that you can do to decrease chronic inflammation that will help your mood.
I'm thinking about, what about the reverse? What about the possibility that the anxiety in and of itself is an irritant causing inflammation?
That's a good question.
Because
Here's what I will say is that the lower your stress levels, you want to lower your stress levels. That stress, we know that stress causes inflammation.
Yes.
So yes, it is a two-way street. Anything you can do to decrease stress is going to help to decrease inflammation. And anything you can do to decrease inflammation is going to help you with your mood, with your cognitive functioning, and with your sleep.
So we're talking about the possibility of decreasing stress and decreasing the inflammation caused by stress, and at the same time, I want to quote from your book, right from the very first sentence of your book, women today are overworked and exhausted. We are anxious and frazzled, yet depressed and burned out. If this is what we're doing to our women, and at the same time we're telling them to reduce stress and reduce inflammation, how do we do it? We've created a situation now where the women are in the workforce the way the men were. The workforce is the place where you're not supposed to show emotion. For gosh sake, how can you possibly cry when you're sitting at work or you're in a law court or you're doing some kind of other job? You have to walk around very serious and straight-faced.
Right.
So we're giving them a double bind. We're telling them, come into the workforce, act like men, keep a stiff upper lip, suppress all the stuff, or take a drug in order to not feel all these feelings, and at the same time, do everything you can not to inflame your system, because that's liable to result in some cardiovascular event.